So I'll go ahead and introduce our speakers. Laurel Bird has been with our dentistry and oral surgery department since 2013. She's a veterinary technician specialist in dentistry, a trainer on dental radiology, a frequent speaker, and she's been published in a dental textbook as well. Heidi Olivier came to us in 2015 from the University of Minnesota's Dentistry Service. In 2018, she also became a veterinary technician specialist in dentistry. I'm very happy for her and proud of her. Her personal interests include pet owner education, assisting with endodontic procedures, as well as teaching fellow vet techs tips and tricks for dental radiology and charting. So today is right up her alley. And we're going to go ahead and get started. I'm going to put the mic on Laurel. Yes. I'll get out of your way here.
Hopefully I won't trip myself with the cord. I used to record traveling. So today we are going to be talking about oral exam and charting for the veterinary technician. This is very much something that the technicians can be doing in your practice. It doesn't need to be a veterinarian. All right, so this is our current dentistry team. We have Dr. Brian and Dr. Vic Carey, both are board certified veterinary dentists. Then myself and Heidi, we have just hired a third technician to join our dentistry team, which will be starting in a couple of weeks. So we're super excited about that. Today we're going to talk a little bit about conscious or awake oral exams. So this starts in the exam room. We don't wait until we have them anesthetized. We do an additional anesthetized exam. We'll talk a little bit about the tools we use to create our dental chart and what you should be putting on your dental chart. And then we'll do a little bit about oral pathology. And so diving right in, your conscious oral exam, this should start the minute you walk into the exam room. So when I walk in an exam room, first thing I do when I'm greeting the owner and greeting the pet is I'm kind of looking at how that pet acts and behaves, what his facial features look like or her facial features look like. I'm looking to see, are they symmetrical? Is the left side and the right side match each other, or is there an asymmetry there? Do I notice any swellings, anything abnormal like that? We want to use all of our senses possible, so sight, so look at them. Smell, we've all walked into the room and had those pets that you can smell long before you ever get there. Touch, feel them, feel their head, their face, their neck. Make sure you don't feel any swellings, soft spots, something abnormal. And sounds. Sometimes we forget that we should be listening to our patients. So as you're petting them, do they groan? Do they whimper? Do they give you any signs that there's an area that maybe is a little sensitive to them? And so really pay attention to all those different factors and do this every time. I do it every time. Even if I'm not the tech who is responsible for a patient, I still look at them the same way. I'm looking to see, are they comfortable? Are they symmetrical? Is there anything unusual? Don't forget your puppies and kittens and even little neonates. We want to be looking at them in the same way and kind of be assessing those same things. So skull type, this we can't really change, but it can give us a clue as to what type of pathology we might be expecting in that oral cavity. So our metacephalic dogs, those are normal skull proportion dogs like your golden retrievers, Labradors. The muzzle and the skull have a normal relationship to one another. And so these are just kind of your average dogs. Everything is spaced where it should be. The teeth all meet the way nature intended them. And so we tend to see less problems with these guys as far as periodontal disease, but they certainly can have fractured teeth and they can develop or be born with malocclusions, and they can have all the same problems as some of our other friends. So our dolichocephalic friends, those are the ones with the really long stretched out faces. They actually have more space between their teeth, but they have all the same number of teeth. So we want to kind of be careful with these guys and really pay attention to what's going on in their mouths. Dachshunds, all of our sight hounds, basset hounds usually have a fairly long muzzle. So kind of keep an eye on those. As far as our cat friends go, it's most of our Oriental friends. So they tend to have that long, narrow face. And then last but certainly not least, our brachycephalic friends, they have the little short wide heads, kind of look like they ran into a parked car. So that whole face, they've taken a normal size muzzle and we've squunched it down into a really small space. They have all the same teeth. They're just compacted into a very, very small space. And so they tend to have a lot of rotated teeth. They tend to have a lot more malocclusion issues. And we tend to see a lot more perio because those teeth aren't meeting the way nature meant them to be. Pugs, bulldogs, boxers, Boston Terriers, those are all our brachycephalic ones or examples of them. And then Persians is the little British short hair. They all have that real short muzzle. So conscious oral exam, so in our exam room, a lot of times that's my first clue that they have a malocclusion. So sometimes you can spot some of these malocclusions just watching that animal move around the room. You'll notice that that chin is too short, or sometimes that mandible's too long and you can see those lower incisors sticking out in front. So you already have a clue. This is what those incisors should look like. You should see all your maxillary incisors out in front of the mandibular ones. And so keep in mind, that's what you should see. That's what you should be looking at. Keep in mind that your lower incisors should all be resting on the palatal aspect of those maxillary incisors on an area called the cingulum. If you look at the palatal aspect of those incisors, those maxillary incisors, you'll see a little hoop-shaped structure on the back of that tooth enamel. And that's where those other teeth are supposed to sit. It's kind of a nice little rest stop for them. Next, we want to look at our canine teeth. The mandibular canine tooth should always be rostral or in front of that maxillary canine tooth. So they should sit in this formation as you see on that picture. The next thing to look at are those premolars. The premolars should make this really nice little zigzaggy pattern. That's kind of makes it so that if they were to chew on something or use those teeth, they can shear off in the wild a piece of meat or whatever. And so nice little zigzaggy pattern. They shouldn't be lined up directly over the top of one another. And there should be just a little bit of space around them. Last, the upper fourth premolar, that should always sit on the buccal or outside surface of that mandibular first molar. So the mandibular first molar, that's that really big wide tooth on the mandible. So that upper fourth premolar should always be on that outside surface. There we go. So we'll talk about malocclusions, things that are weird, things that are odd, as far as how the teeth sit in relationship to one another. And so malocclusion class 1, also called nutrocclusion, these everything for the most part sits in normal relationship. Our incisors, canines, and premolars all sit where they should, but there's usually one or two teeth that are unusually placed. And so here you can see on the picture on your left, we have a little second incisor that's actually on the lingual aspect of those lower incisors. So that's a malocclusion. That tooth is probably not real comfortable because every time that pet closes its mouth, that tooth is hitting the teeth down below it. So we've got pain both on our mandible and maxilla as those come together. And then over on our picture on the right, you can see that our upper fourth premolar isn't even hardly visible. It's actually pushed to the lingual aspect of that lower first molar. And so that's malocclusion as well. It may be uncomfortable for that pet. It just depends on how those teeth come together. Class 2 malocclusions, these are mandibular distocclusion, or our mandible is too short. Most commonplace thing we see with these malocclusions are base narrow canines. Not always, but we do see quite a bit of them. And so here we have a little puppy. You can see these are all baby teeth. You can see how tiny they are, lots of space between them. But you can see on the picture on the far left, that mandible is at least a centimeter too short. And when you look at the center picture, you can't even see his mandibular canine tooth. It's hidden by the maxillary canine tooth. And when we opened his mouth, you can see on the far right picture, you can actually see where that canine tooth is poking into the roof of the mouth. So that's a really painful condition. This puppy's not going to act painful. He doesn't know any better. This is how his teeth came in. It sure probably was painful, but he just doesn't know any better, and he doesn't know how to tell you that it's painful, so he's still eating, he's still playing. He maybe doesn't play with as much gusto, because every time he tries to grab something on that side, it probably hurts. A lot of these guys will close their mouth, but they don't close them tight like they should, because it just keeps driving the point of that tooth further up into the roof of the mouth. So our class 3 malocclusion, these guys, the mandible is too long. And so these are our boxers. All of our brachycephalic friends usually have a mandible that's too long, and those lower incisors sit out. And you can see those maxillary incisors, look where they're hitting. They're hitting right where those lower incisors hit the tissue, the floor of the mouth. And so that's painful too. We usually get a lot of tissue trauma there, and sometimes enough that it actually starts eating into the teeth, those lower teeth themselves. And so, yep, trauma right there. And so the last one is our class 4 malocclusions. We used to call these ribites. They've changed that terminology. They just call them a class 4 now. But these are asymmetries. So this is a left or right asymmetry. And you can see we've got a canine tooth. He looks like his jaw has shifted over to one side. Here's a kitty, the jaw has shifted to one side. And we usually see these guys in as trauma. It may not be trauma right now. Some of these, the trauma happened back when they were really little puppies and kittens, and it affected the way the bones grew on one side of the face. So it may have halted that growth. And so the one side grew to a normal length and the other side kind of stopped and didn't progress as much. And that kind of makes the whole face kind of shear to one side. And so asymmetry most likely causes trauma. Years ago, those of you who were around several years ago, remember they had a Flip the Lip campaign. That was a real big thing in dentistry, and it still is. It's really important, I feel, when you're in the exam room to lift that pet's lip and look at the teeth in the exam room and show the owner what you're seeing. A lot of these owners have never lifted the lip on their pet. They have no clue what is in there. And so it's my first chance to check their occlusion and mention if I see something unusual to the owner. I can do a real quick mental count of the teeth, see if there's something missing or if there's something extra. And then I can check on how much calculus or gingivitis is there. And that again is something to show owners, because they may not really understand what they're looking for when we talk about calculus and gingivitis. And last, kind of note which teeth are fractured and any other pathology. And I show these things to the owners. I'll be like, ooh, this looks really ouchy. Did you see this broken tooth? And a lot of owners are like, oh, do you really think that's painful? Because their dog is still eating, he's still playing, and they don't understand how painful that is. But if I had a broken tooth, I'd still be eating, I'd still play with my grandkids, but I probably wouldn't be doing as many things on that side of my mouth. I might chew on the other side or just avoid chewing anything hard at all. And so here's a really good example. This is a golden retriever. So this is one of our normal skull dogs. We don't expect a lot of problems. And when you lift his lip, those incisors and canine look really good, right? And then you lift his lip further back. And that's what you see. So if I only looked at the front of his mouth and showed the owner the front of his mouth, they'd be like, that's not so bad. I don't see anything scary. But when you lift that and show the owner, they can see the difference between the two. It's not real common here that we extract teeth whole and block like that without sectioning a tooth. And so you can see, though, the entire root structure of that upper first molar is entirely covered by calculus. So there wasn't really anything holding it in except sheer willpower, maybe. It stuck in there somehow on its own. And that's a really uncomfortable mouth. If you touch that area, that dog is probably going to wince and shy away. Even if his lip was down, if you were palpating on that side, you might find that that dog kind of flings his head around and doesn't want that portion of his face touched. So next, so any questions on awake oral exam? Okay, so this is our extraoral exam. This is after our patient has been anesthetized. We put a trach tube in, we look at everything, and now we're starting to check things out and make our dental chart. So extraoral, we want to look at and feel. It's kind of one last feel. You feel the muzzle. We feel their zygomatic arches, the bones around their eye. We feel their mandibles, and we feel the lymph nodes. Remember that there's lymph nodes right down at the corner or angle of the jaw. There's also salivary glands there. So get some anatomy books out and look at where are lymph nodes, where are salivary glands, and what do they feel like. And if you're not sure, get everybody around, everybody feel, or if you find something abnormal, have your vet feel and have them tell you what they think that is and what's there. Be really meticulous about your exams. You'll notice that the picture on the right has a little tiny black bump on the lip margin. It's really easy to miss those little masses because they just look like the little finger-like projections along the edge of that lip margin. But those are really important. We want to make sure that we have those removed or note those so that the vet can remove those and send them in for pathology and find out what they are while they're still little. And so right there you can see that mass. So mandibular lymph nodes, as I said, are right at the angle of the jaw. There is a large salivary gland there, so you'll probably feel something that's, dog this size, about the size of my thumb. That's the salivary gland. That's not usually the lymph nodes. So feel for the lymph nodes. If they're normal, they should be much smaller than that. When you're placing a trach tube, make sure that you are looking at this oral cavity way at the back. It's a good time to look at it. You'll notice our picture over on the right, picture on the left. You can see our tonsils there. They're out of their little crypts, but they're still not real red and inflamed. So I would probably note that, yes, I can see the tonsils, but they don't look lumpy, bumpy, and asymmetric or unusual. And then if you look over on our picture on the right, you'll notice that little entrance to the trachea, notice how bumpy and uneven that looks. That's something really important. I don't want to put a trach tube in there until my vet has looked at that. So if you see something unusual back there, call your vet over, have them look at it before you put a trach tube in there. Once you get the trach tube in, you can rough up that tissue. You might have something that they want to see, and once the tube is in, they can't see it as clearly. So make sure you point those things out before you get your tube in. So next I'm going to start looking at the tissues in and around the oral cavity. So on the left here, we're looking at the buccal mucosa, and you'll notice how bumpy and rough that looks. That's called cheek chewer's lesion, or buccal granulomas is another term. This is tissue, it's just exuberant cheek tissue that the pet has bitten down on repeatedly, and so it's become really kind of firm and knobby. There's not a lot that we do about that, but it's something to note in the medical record. And then our little friend over on the far right, this little cat who has stomatitis, you can see that the red extends well beyond just the gum tissue. This isn't just gingivitis, this is stomatitis. We've got a red caudal portion of the oral cavity, the buccal mucosa is red, and under the tongue it's red and irritated. Gingival index, we always want to grade, so kind of put an overall assessment for our gingivitis. So gingival index 1, it's mild. There's some redness to the gingiva, that tissue right around the teeth. It's a little bit uneven or swollen. It doesn't have that nice little knife-like edge where it lays close to the teeth, but it usually doesn't bleed on probing. And that's not this patient. Grade 2 is moderate, so there's more redness, more swelling, but it usually bleeds once you probe it, but it usually doesn't bleed like if you just were to blot it dry or to just look at it. So that's grade 2. And then grade 3 is spontaneous. So this is stuff that bleeds when you just look at it, or you dab it with a gauze and all of a sudden it just starts oozing everywhere. And it makes it really hard to probe because it just won't quit oozing. So that's grade 3. So be sure you're recording that. And then our hard and soft palate. Our little friend over here on the left, this is a little kitty named Steve. He came to us, and when we did his oral exam, his hard palate looks just fine, feels just fine, but when you get to his soft palate, here he has, this little tiny hole way at the back of his soft palate. The arrow that just popped up, that's actually pointing at his incisive papilla. This is a really normal structure on dogs and cats. It can vary in size. Sometimes it's really large, sometimes it's really small. So know that that's a very normal structure, and you should see it right behind the incisors. And then there's a little hole in Steve's soft palate. So that definitely needs to get repaired. That just lets food and water, anything that goes into his oral cavity, get up back into his nasal passages and sinuses. And then over here, we have a kitty who has an abnormal hard palate. You can see that bubbly tissue coming out by the teeth. You can see that we're kind of losing all the definition of his hard palate. And so again, we want to note that. We would want to write that out on our chart and kind of draw out where that swelling is. And last but certainly not least is the tongue. The tongue can be a little bit tricky. You have to pick that tongue up and look on the left and right sides and look all the way underneath the tongue. Lots and lots of oral masses can hide there. Some of them are really small and discreet, and other ones are really awful, like these two guys. The one on the left is a cat, and you can see that bumpy tan and red eroded tissue. And then the one on the left is a dog. The surface of that dog tongue looked fairly normal. It maybe had just a little bit of a swollen area to it, but when you flipped it over, you saw this really big, ugly mass. So now we finally looked at all the tissues except the teeth, and now it's time to finally look at the teeth, which is what we all really like. So this is where you need to know your dental formula. Dental formula, a lot of people get a little freaked out by it. It's really easy. The I, C, P, and M stand for incisor, canine, premolar, and molar. And they tell us how many teeth that pet has on the maxilla and mandible on one half of their head. So for a dog, we have 3 incisors on the top and 3 on the bottom, a canine tooth on the top, canine tooth on the bottom, 4 premolars on the top, 4 premolars on the bottom. Molars is where they're different. They have 2 molars on the top and 3 on the bottom. The ×2 is just for our left and right halves. When you add those all together, you have 42 teeth. So make sure that you know you should be able to look at a dog or a cat, even in the exam room, and just mentally look and go, ooh, they're missing a tooth here, or they've got an extra tooth here. Cats have a lot less teeth. Cats only have 30 teeth, and they're pretty easy. I mean, most cats have 3 teeth across the bottom. They have those 2 premolars and a molar. And on the top, they actually have 3 premolars, and that molar is tiny. Their molar on the maxilla is buried behind that upper 4th premolar. So it's a really little guy. But a normal cat should kind of look like that. Again, don't get bit trying to see into mouths, but if you can see into them in the exam room, it's really helpful to show owners anything unusual. These are 2 nice examples of extra teeth. So we have our little barracuda over here on the left. This little pup just did not shed those deciduous teeth when it should have, and so it's got lots and lots of extras. All those extra teeth need to go. They're just forming a nidus for infection and periodontal disease. They create spaces that are too close together and just allow areas for a lot of bacteria to get in and just sit there. On top of which I wouldn't want to be bit by that. Our little cat friend over on the right, remember that cats behind their canine are supposed to have 2 premolars and a molar. And if you count, there's actually 4 teeth there. So we actually have 3 premolars and a molar. So we've got an extra tooth there. And you can see all the periodontal disease this poor cat had. So missing teeth. So missing teeth are really important. Just because you don't see it there doesn't mean we don't have to worry about it. So this was a sweet little golden retriever who came to us. She had gotten all of her adult dentition, but she was missing her lower canine tooth. And she's maybe the exception to the rule. she actually, you can see that area looks swollen. It doesn't look real normal. And so there was reasons to be concerned. When we did her x-ray, lo and behold, our canine tooth really was there. So was our first premolar, which is kind of halfway upside down on the picture on the upper right. And you can see our canine tooth real well on that lower picture, that lower x-ray. You can see that root is not normal, and that's why this tooth didn't erupt, because it doesn't have normal structure, so it's not going to advance normally. And the biggest problem with these missing teeth is that that enamel was never meant to be buried. It's meant to erupt and be exposed to the air. This is buried under there. The body does not like that, and so it starts trying to wall it off, and it forms a big cyst around them. And some of these pets will go years and years without forming a cyst, and others will do it as Lacey did long before she was even a year of age. And so this cyst can be locally destructive to bone. So we want to really get these out. Even if they don't have a cyst, we want to get those unerupted teeth out as soon as we notice them. All right, so now we're going to start talking about doing our dental chart. And the two instruments that we use the most for a dental chart are a dental probe and our explorer. The probe is like your ruler. It's your measuring guide. They come in a lot of different conformations, but this is like my favorite one. This is a UNC 15 is what it's called. It's a really easy to use probe. Each mark is 1 centimeter until you get to the really big wide black one. The bottom side is 4, the top is 5. And I said centimeter, I meant millimeters. So that from the end of the probe to the top of that first dark black mark is 5 millimeters. So if that all goes down into a pocket, I know I have a 5 millimeter pocket. If I go to the top of that next black mark, then it's 10. And to the top of the very last one, then it's 15. So that'd be a really deep pocket, 15. I had one the other day and I was measuring 13 millimeters. So it was a really big pocket along a canine. The instrument next to it is usually the opposite end of our probe, and so that's our explorer. They can be on 2 separate instruments, but I find it helpful to have them both on one because I can just flip my instrument around to use that explorer if I need to. Your explorer is used to find tooth resorption along the hard surface of the tooth. So you'll never point that explorer towards the soft tissue, but you'll always point it towards the hard tissue of the tooth. And I use it a lot right at the gum line or just below the gum line to feel if there's a rough structure there or a rough area. Here's some other examples of probes. So you can see they do come in different conformations. If you don't know how many millimeters each mark is on your probe, get out a ruler, a metric ruler, and measure it out so you know what you're measuring in. And so ergonomics, you want to hold this with a modified pen grasp. So hold it kind of like a pen. You're just going to shift your fingers a little so you've got those first 2 fingers resting on it. It's a light grasp. You don't need a real hard, firm grip. You want to be able to tactily move this along the tooth. And you're going to slide it in the sulcus and you're going to measure around that tooth. And so here you can see we're measuring around the lower canine, and in the picture on the right, an upper 4th premolar. You want to keep that instrument parallel to the long axis of your tooth. So you want to keep it in line with that tooth. So you don't want to tip it forward or backward. Cats should have less than a millimeter, and even your small dogs. Little Chihuahua, if he has a 3 millimeter pocket, that's a pocket. That's pathology. That's not normal for a Chihuahua or a little tiny dog to have a real deep area like that. For our medium and larger dogs, they can have up to 3 millimeters. But again, anybody who's going to that dark black bar to the bottom of it or the top of it, that's pathology. That's a pocket. And so when we're measuring around our tooth, we want to do at least 6 measurements around each tooth. So 6 on the buccal aspect and 6 on the lingual or palatal aspect. And so here you can see we have arrows at the 3 areas we want to measure. We usually are measuring even in between those just to make sure we don't miss anything, but for sure those 3 areas. So you have your mesial buccal, you have your mid buccal, and your distal buccal. And then on the lingual or tongue side, we have our mesiolingual, our midlingual, and our distal lingual. Usually I'm not saying those whole words when I'm calling out my numbers. If I'm the one probing and Heidi is charting for me, I will tell her what tooth number I'm on and then what my pocket depths are. So I might say 309, and she'll know that I'm on my lingual aspect, but if she didn't, I would say lingual, and I would say mesial 3, mid 2, distal 5. And so she would know. And sometimes I might even cut out the words and just say 4, 3, 5, and then she knows the order that they're in. So palatal teeth or maxillary teeth have palatal aspects. They don't have a lingual aspect. And again, they have those 3 spots. So we have our mesial palatal, the mid palatal, and the distal palatal. And every single tooth on the maxilla will have those measurements. Every tooth on the mandible will have those measurements. So dental charting is a technician's skill. You definitely need to work with your veterinarian so that they are comfortable that you're finding all the pathology. So it starts out as a team activity, working with them, and once they're comfortable with what you're doing, you and another technician can do this. It is a written record. You'll notice where I'm charting there, I am using a pen. I don't like pencils when we're doing charting. If I make that many mistakes, I'll make a new chart. But hopefully you're not making too many mistakes when you're doing it. But use a pen. It's indelible. It won't get smudged or smeared. Pen can get erased, or pencil can get erased. So again, use a pen. This is part of their legal medical record. So we scan ours into our computer system when we're done. And then four-handed dentistry. Four-handed dentistry means you've got 2 people doing it. So Heidi is doing all of the oral exam and measurements, and she is talking to me and calling out all of the pathology that she finds. It's pretty rare that we're real quiet throughout a whole mouth, and so if it's real quiet, I'm like, aren't you finding anything? And she'll be like, no, for once we don't have a lot of pathology. Sometimes we say things in our head and we forget to mention that there's a missing tooth or something. So you'll notice I'm standing fairly close. I want to be able to, like, if she calls something out, and sometimes you call out the wrong number. You say, 108, and you really are on 208. So at least I'm nice and close to her so I can hear what she's saying, and I can look and I can go, 208. She'll be, oh yeah, 208. So sometimes we just get too many numbers in our head. And so this is the dental chart we use. I know it looks really confusing when you first start, but I absolutely love this chart. But it's got things that all basic charts should have. So you want that occlusal view of the teeth. We have an area where we're going to put we have a little label that we print out that has the owner's name, the pet's name, and signalment on it. We've got little spaces on the upper left where we can put the date, and we always record which veterinarian and which technician worked on that pet. And then all of our little boxes, which look overwhelming, right? Kind of scary and overwhelming. So the first thing you'll notice is the top 2 lines have label each tooth. So it gives them their label as far as incisor, canine, premolar, or molar, and if they're the first, second, third, or 4th. And the line below it gives their triad number. So 101, 102, 103, and so on. The top row is all our maxillary teeth. The bottom set is all our mandibular teeth. The next one is buccal, and the next one says palatal. Those are our probing depths. So as we're probing around and Heidi calls out numbers to me, I will write those numbers. If she's on the buccal surface of the tooth, I'll write them in the box for buccal. If she's on the palatal aspect, I'll write them in the palatal aspect box. And then we have recession. So if she finds gingival recession, she'll measure how much recession that is with her dental probe, and she'll tell me how many millimeters of recession we have. So we'll record that there. Furcation, you'll notice we have a series of boxes that are all blocked off. That's because those teeth don't have a furcation, they're all single-rooted teeth. If there's a furcation exposure, we want to record that, and we'll talk in a minute about what is a furcation exposure and how do we rank those. And at the bottom, we have mobility. If a tooth is mobile, we need to record that. We often see loose teeth, and mobility can be a little bit subjective. So get together with your group so that you can agree on what is mobile 1, 2, and 3. And we do have some parameters for you to follow, so that might be helpful. You'll also notice at the bottom here, we have a little key. This gives all the most common abbreviations that we use on our chart. You also see there's some little lines at the far lower right. That's where we can write abbreviations if we come across something that we don't have an abbreviation on our chart for. And those abbreviations will be used on that occlusal view out and around the teeth that we find those various pathologies. The column on the far right, you'll also notice has our extra oral exam thing. So it reminds us to look at things like our oral pharynx, our tonsils, the mandible, the buccal mucosa, the tongue, and the hard and soft palate. And so it has a normal and an abnormal. So if we found something abnormal, we would circle the A, and then on our comment section, we would comment on what we found. We have a 2-part chart. Our second page has the treatments. And so this is the first one. This one is what we found when we did our exam. The second one is what did we do to treat that. The only thing we transfer from the front page to this page is any missing teeth. So if there's missing teeth, we would color them in black, and so we would transfer that here so we know what we started out with missing. We have our own, it's got its own little set of abbreviations because these are all now treatment abbreviations. And so we did up a little recession here. This is what you would see for recession or an example. And so Heidi would take her probe and she would measure that entire area where the blue bracket is and tell me how much recession that is. Furcation exposure. So this is our multi-rooted teeth. This is how far your dental probe will go underneath that tooth. So ideally it won't go anywhere. Usually you can't even find that furcation, but an F1 would be less than 25% bone loss. So basically as I'm probing, and when I go turn my probe so that I point it at that furcation, I actually fall into that furcation a little bit, but I don't go very far. I just kind of can find it in an area where I normally wouldn't expect it. F2 is 50% of the way. So when I turn my probe in there, my probe goes in, and it goes about halfway, but it doesn't come out the other side. F3, which are these little guys, your probe's going to go all the way through. It's going to come out the other side. And so those are pretty severe. Sometimes we don't have as much gingival recession, but these teeth definitely have a lot of pathology that we'd be reporting on their chart. And then mobility, yeah, right? You see those and you know that they're all mobile, right? So mobile slight is anything up to about 0.5 millimeter. So use your probe, wiggle that tooth, measure how much it wiggles with your probe if you have to get an idea. But slight, so it's going to move just a little bit, but it's not going to dance around in the socket. Moderate is up to 1 millimeter of motion, either sideways or back and forth. And severe, which probably is these guys, they're going to dance around in the socket, and every now and then we'll call out, yeah, mobile 3000. So we know it's ready to just about fall out on its own while we're probing. So don't be fooled. Sometimes we do have a lot of gingival recession, and those teeth are pretty solid. They're not as mobile, and so those ones can be real stinky for our vets to extract. So here's a dental chart that Heidi did up for me. It's just kind of a basic chart. It shows you how to use a chart like this. So you'll notice that we recorded our gingivitis and calculus indexes. We did our extra oral exam on the far lower right. And then we used our abbreviations from our abbreviation log to tell what was going on with the teeth. So the tooth on the upper left is actually 108 as your patient's laying on his back. And so their right side is over here, and you can see we got our little R and L. And you see she has T/FX/CCF. So that tells us that it's a tooth fracture, and it's a complicated crown fracture. So that means that that tooth has been fractured into the pulp. And on the bottom, she has GE, so that stands for gingival enlargement. And she has measurements. So it measured 5 millimeters by 4 millimeters by 2 millimeters. So she used her probe to measure how thick and how wide that little gingival enlargement was. And then you'll notice on our little abbreviation chart, we went through and we circled the abbreviations we used. It just makes it easier for anybody who gets our chart and looks at it to quickly find the abbreviations we used on our chart. And then you'll see right here on 304, she had some pocketing, and so she has written 3 really tiny 4, 4, 4. So on the buccal aspect, she had pockets of 4 millimeter, 4 millimeter, and 4 millimeter for her mesial, mid, and distal measurements. And then on her treatment sheet, you'll see the black teeth. Those ones, if you look, you can see the blacked out teeth. Those are her missing teeth. And so on this chart, she's copied over those missing teeth, but she didn't really copy anything else. You'll see that tooth 108 has a big X on it, and she has XSS by it. So that tells us that we surgically extracted that tooth. So the vet went and sectioned it into 3 single roots, and then extracted each root and sutured the socket closed. On the lower left tooth, the lower left canine, BI stands for biopsy incisional. So we either used a punch biopsy or we cut into that mass. So we didn't take the whole thing off. We just took a sample of it. And then C or RP/C tells us that we did root planing closed. So we didn't make a big flap to clean the root. We just used our curettes and went subjugally. Over on the upper right, we went through and we listed out what we did for our block. In the treatment sections, she put PRO and FMX. That tells us we cleaned the teeth and that we did full mouth x-rays. And then we list out the other treatments we did. And we have our radiographic findings, which the vets fill in, and then follow up what needs to be done. So we need to do a recheck on this patient, and at that point, we'll give them their biopsy results. This is what a messier chart looks like, a patient with a little more pathology. So you'll notice there's a lot more numbers in the boxes. Notice that there's still not a lot written out on our occlusal view. So we didn't have a lot of like fractured teeth. We had a couple different things going on there, a couple missing teeth. But by looking at this chart, I would know right away our maxillary half of the mouth is our problem, and the upper right has a lot of teeth that are going to go or that have a lot of problems. And then the left has some too. The right, lower right, doesn't have as many. Just our 409 has a bunch of measurements around it. And so it's kind of a nice way to quickly see what's going on with those teeth. And then her treatment sheet, you'll see, is much messier. You can see all the teeth that were extracted on this patient, and you can see all of our abbreviations really help, because where we had to write out what we did for treatments and radiographic findings, we can use all those abbreviations rather than writing everything out longhand. Okay, questions about the chart? All right. Is everybody using a dental chart?
We got crappy ones. Do you have any? Do you have any here?
We have that chart, and then we probably have a few other charts, but yes.
All right, so we're gonna talk this last little section about some oral pathology. So anything abnormal that you're gonna find in the mouth. So how I'm gonna lay this out is we're gonna show you an image of a patient that we've seen. We're gonna kind of assess based on what we're seeing, and then I'll let you know what the diagnosis was. So our first one here is something that we've probably all seen a million times. These are 2 cat patients. What we have here are 2 pink to red lesions down at the gum line. Usually when we're viewing this and we're taking our probe and our explorer along the gum line, you're gonna get a pain response. So usually your pet's asleep from their anesthesia, you go ahead and you probe along the gum line, and there's jaw chattering, their heart rate might increase. If they're not asleep enough, they might be trying to wake up, and that's going to tell you that that's painful. So we all probably know what this is, tooth resorption. Unfortunately, The only way to treat tooth resorption is with extraction or crown amputation. That is something that you have to have an x-ray to know how to treat which type of treatment for that. So here we have a really kind of interesting, I like this case because on initial exam, you don't really see a whole lot going on. The tooth itself has a fair bit of calculus, but if that dog is here for a dental cleaning anyway, you're expecting that. But on closer examination, you see the faintest kind of line on the mesial cusp of the tooth. When we go in there, and you've probably all seen this. This is a complicated crown root fracture, what a lot of people commonly refer to as a slab fracture. This pet was probably chewing on something inappropriate, something too hard, and just the way that our pets chew and the way this tooth is designed, this is usually the first tooth to fall victim to that fracture. So some counseling was needed on appropriate chew toys after this one. So this tooth, unfortunately, the way that it was fractured had to be extracted. So this is another really cool case that I like. And I like this because this is not the lecture we're talking about, but the importance of dental x-rays. We have a whole other lecture on that. So on initial exam, it's not too bad. The tooth looks pretty healthy. It's nice and white and shiny. We obviously have some gingivitis down at the gum line. If we took our probe and explore, we might get a pocket there in the middle. You can see it's pretty red and angry. There's something weird going on in the mid-body of that tooth. There's a defect or there's a previous trauma. There's something going on there that we said, we're not just going to ignore that. We're going to take our x-ray. And so in this case, this tooth was highly infected. So had two, and actually the tooth behind it too. You can see two actually periapical abscesses. So this tooth, unfortunately, either needs to be treated by extraction, or we could potentially offer them a root canal therapy as well if they decided they wanted to try to save this tooth. So this dog, I'll give you one guess on what kind of dog this is. Yeah, everyone knows it's a boxer. We see it in other patients, but usually it's a boxer. It's where, you know, we're seeing this really proliferative tissue. Sometimes it can be focal and just really, you know, on one tooth. In this case, this is pretty severe. It's on the whole mouth. That whole upper fourth premolar is completely covered in tissue. The thing I want to say here is Laurel talked earlier about gingival enlargement. Until our eyes are not microscopes, right? We don't know what this tissue is. This might be really benign, or it could be something bad. We don't know until we've sent it off to the lab to be identified. So we're not going to give this a diagnosis until we've sent it off to the lab. So in our charts, we're going to note that this is just gingival enlargement until we know otherwise. In this case, obviously, we knew it was gingival hypoplasia, and but that's what our diagnosis told us when it came back. Again, this is a different type of gingival enlargement, so it looks completely different to what we saw before. This is just focal on one tooth. This is a lower canine and a large dog. We know it's abnormal because it's taking up about half of the tooth. It's not supposed to be there. So we went ahead and we removed that tissue, sent it off to the lab, and this came back as something benign, so thank goodness. It came back as something called peripheral odontogenic fibroma, or POF, if you want to make your life easier. This is what a lot of people commonly used to call or still call an epulis. So that's an old term. We don't really use that term anymore. So we really want to have our diagnosis before labeling it a quote unquote epulis. So this one, kind of in that same instance of gingival enlargement, except this time we're actually going to call it an oral mass. And the reason we're going to make the distinction here is because it's actually extending beyond the gingiva, going it past that mucogingival junction and into the buccal mucosa. You can also tell that it's much redder, it's angrier, it's more vascular. So we're a little bit more concerned about this one. Again, we're not just going to lock this off. We need to know what it is. So we send it out for biopsy. We take a piece of it, send it in so that we know how to treat it. And this one, unfortunately, came back as a papillary squamous cell carcinoma. This dog came back and had a partial maxillectomy and did just fine. So this one, I really like this picture because, so what you're looking at is the inner, it's upper right lip, on the inner lip. of a dog. So I think this was a King Charles Cavalier. And that's tricky because there's a lot of pigmentation. There's a lot of really dark darks and there's a lot of really light lights. So it can be tricky if you're not paying enough attention to those other tissues. You might miss this completely. So that little black raised little mass is something that we said, that looks a little suspicious. So we took a biopsy sample. I sound like a broken record, right? You're gonna biopsy it. You're gonna send it to the lab. We initially called it an oral mass, but when I came back, that was oral melanoma. So that's something we don't want to miss on our oral exam. So I know we're all excited about the teeth and we want to get into the teeth, but this is why that full extra oral exam is extremely important. So this is a tooth number 109, so an upper molar in a dog. You can see that that tooth has a lot of erosion into the pulp. This is a really extreme case. A lot of times we'll see this when we're probing with our probe and our explorer. It's just ever slightly so sticky. And this is what we call a carious lesion. So it's kind of equivalent to human, what we equate with cavities. This tooth is too far gone. It needs to be extracted. But you know, if we catch them early, if you're really astute and you're seeing those on your oral exam, we can sometimes save these with a restoration if they're not already into the pulp. So this is a pretty benign thing, usually. You've probably all seen this. This is on your, you can see the leveling of the teeth. They're worn away, and it's usually caused by an abrasive surface. Usually, that's a tennis ball. We usually call this tennis ball wear. So your dogs that are just obsessed about chewing on those things usually have this type of wear on their teeth, and it's called abrasion. So abrasion is something we refer to as just chewing on another object. So whether that be a ball, a fence, a cage, whatever, that's causing abrasion. So this can be a really benign thing. It's something that we kind of keep an eye on with our x-rays and things like that. I have seen it where they're completely worn all the way to the gum line and those teeth are now fractured, and then we need to do something about it. So it's something definitely that you need to have your x-rays and be keeping at least an annual watch on those. I'll also give you a guess on what kind of breed this is. This is a boxer as well. So what you can't see is that this boxer has a class 3 malocclusion, which we talked about earlier. And what we learned about class 3 malocclusions is that sometimes you can see trauma from those upper teeth hitting on the lower teeth. So this is called attrition. The difference between attrition and abrasion, attrition is a tooth-on-tooth contact. So if you can remember the T's on attrition for tooth-on-tooth and abrasion for ball, that's how I remember that. But you can see that constant hitting from the upper teeth onto the lower teeth is really causing severe damage to the lower canine teeth. So it's something that we should be aware of and ideally take care of way before it ever gets to this point. And you can see in the middle as well the trauma to the mandibular floor. So at this point, we might need to extract both canines, do something to the bottom there to repair that, and then maybe treat the teeth on top that are causing trauma as well. So if this were maybe intervened earlier in life, we wouldn't have this big problem. This case I really, really like because on our awake oral exam, this dog initially came in for an extraction of an upper fourth premolar. And we said it was fractured. We said, okay. On our awake oral exam, we said, this dog has a bleeding disorder. You know, we thought this was petechia. So we all said, okay, we were gonna do our pre-op lab work anyway. So we did our CBC, our chemistry panel, and our PCB. That was completely normal. And we said, oh. So then we did some co-ag panel. That was normal. And then we said, okay, so then we did a buccal mucosal bleeding time. That was completely normal. And then we said, all right, let's anesthetize this dog and extract the tooth that they came here for. So we did that. The patient did fine under anesthesia. But before we woke the patient up, we said, let's take a biopsy of that because we have no idea what that is. This came back as lymphoma.
No way.
So something that you might think is something else may come back as something completely else. So if it doesn't look right, if it doesn't look like it belongs there, if you're questioning it, take a biopsy sample. This one here is a really young dog. It's kind of hard to appreciate. But there is some enamel missing from the tips of those teeth. You can see that lower, or the underneath layer, the dentin, more porous layer is exposed. This is what we call enamel hypoplasia. This is a young dog, so something happened either in utero or something where these teeth were being formed. Something happened during the formation of these teeth that caused these teeth to not be developed appropriately. So this is something that we would need to treat, ideally with some sealants. It would need pretty aggressive follow-up usually, if annually, if not every 6 months. They need to be in for cleanings to make sure that those are still healthy. This is my last one. We'll end on a big one, which I really like this case. And I like all the cases. So this one, so initially you look at this dog, and so this dog came to us from a humane society, which I really give them a lot of credit because you have limited things that you can do usually in a humane society. But they looked in this dog's mouth and they said, "That's weird. He's not very old. He's missing a canine tooth." And as we learned earlier, we always need to take an X-ray of our missing teeth in general. So they did that. And what they found was an unerupted canine tooth. So that tooth was malformed for whatever reason, was completely unerupted. Luckily for us, this hadn't started to form a cyst yet. So our talented dentists were able to go up into the maxilla, as you can see, and actually see that right tooth just sitting there on the right, and go ahead and extract that tooth. So if we had let that tooth fester and then it caused a cyst, that would be a whole big problem for this dog. And not a big note there. So that's it for oral pathology and the rest of our lecture. I did want to say, if you love dentistry, as you should, if you've ever not been to the Veterinary Dental Forum, they do it every single year. It's one conference just on dentistry, and this year it's something in Dallas. So check it out.